How is everybody doing? Can you hear me? All right, excellent. We have 8 participants so far. There were 14 registered, so we will give it 60 seconds and we'll get going here. Welcome everyone. Hope everyone is doing great on this Wednesday. We're waiting for a few more participants to get on, but we're not going to wait too long. We're going to get started here very shortly so we can wrap it up in 30, maximum 40 minutes. I think we can wrap it up in half an hour so everybody can go back to work, right? Okay, so welcome to our live webinar today. My name is Dr. Mike Van Thielen, and you can find my credentials on the About Us page on the website genetictestingnow.com. Today, we will be discussing genetic testing and pharmacogenetics in the clinical setting. And before we get started, I would like to share with you that I will not be trying to sell you any service or any product during this webinar. And even when you decide to integrate these innovative medical services, such as genetic testing and pharmacogenetics, into your clinical setting, there still will be no cost to any product or any service. So, if you are a busy, caring, open-minded healthcare professional who is interested in improving the quality care of your patients and who believes in innovative, advanced medical science, we at Genomics, we can certainly help. Because our innovative services, the genetic testing, don't cost anything. It requires no or minimal extra time at the office because it's a simple buccal swab, which takes maximum 20-30 seconds, and there's no extra skill required either. So today we will discuss the reality of drugs and drug interactions, and we will show you some statistics from the CDC. We will discuss the science briefly. We will go over the patient and the provider benefits, and we'll tell you on how you can get started with genomics. We will have a short FAQ question section, basically, and we will finish today with a live Q&A. So, as a healthcare provider, you probably have experienced one or more of the following: patients that are difficult to manage, patients with undesired drug interactions, and patients with unexplained medical conditions. Now, what frustrations do you as a healthcare professional experience most often with your patients? And if you like, you can share that with us with typing it in. But what I can tell you is that you are not alone. And so here are some staggering statistics from the CDC. Approximately 1/3 of all patients do not respond or have a negative reaction to certain medications. And so in the United States alone, on a yearly basis, there are over 2 million ADRs, adverse drug reactions, resulting in over 100,000 deaths. Those adverse drug reactions cost us annually over $177 billion. Now, when it comes to the morbidity and mortality, the annual cost exceeds $500 billion, which is about 20% of total US healthcare expenditures yearly. And that's because when we prescribe medications, we utilize a one-size-fits-all approach. So when we look at this graph or table, it represents the percentage of the patient population for which a particular drug in a class is ineffective on average. Antidepressants, 38%, asthma drugs, 40% ineffective, diabetes drugs, 43%, arthritis drugs, 50% ineffective, don't work, Alzheimer's drug, 70%, cancer drugs, 75% ineffective. Besides that, we also have common medications with known risks, and those risks are actually on the label, on the insert of the medications. This is an example, Plavix, a blood thinner. Warning says diminished antiplatelet effect in patients with 2 loss-of-function alleles of the CYP2C19 gene. So it says that the effectiveness of this medication, Plavix, depends on the conversion to an active metabolite by the cytochrome. And so it even says that tests are available, and they're obviously talking about the PGX or the drug interaction test, to show whether or not this patient is a poor metabolizer for Plavix. And if the patient ends up being a poor metabolizer for Plavix, they recommend using another platelet inhibitor, in other words, changing medication. Besides those drugs and drug interactions, all of us are very familiar with idiopathic diseases or medical conditions, meaning the cause of these diseases is unknown. Often the patient has an exclusion diagnosis, which means is there's no positive test. We really don't know. We can't pinpoint what the cause of the disease is. So we basically label them with a diagnosis. A good example, obviously, is fibromyalgia. We also know that usually there's not just one causative factor of a disease, and many times we have a combination of a mix of causative factors. And then obviously there may be a genetic component at play. So certain people are predisposed or have a higher risk for certain medical conditions. Now, what is the solution for all of this? Well, at Genomics, we provide very simple evidence-based tests that may address these problems that we have with our patients. The first test we call PGX. PGX stands for pharmacogenetics. So we do a drug interaction test. The other tests are basically simple genetic panels. So we could do a cardiovascular screening or a cardiovascular panel, which tests 177 genes. We can do a cancer panel, diabetes panel, a neurodegenerative panel, which includes Parkinson's, Alzheimer's, dementia, etc., and a pulmonary screening. Let's talk a little bit more about that PGX or pharmacogenetics test, drug interaction test. Again, when we look at this picture here, we see that people are prescribed the same medication over and over again. There's a one-size-fits-all approach. And when we do that, obviously, certain people will have no response. Other people will have a desired response. And then some people will actually have serious side effects. And when we talk about this drug interaction test, we need to make sure that we understand this properly. A drug interaction test does not test the interaction between the drugs that the patient is on. No, the drug interaction test basically tests the genome. That's why this is also a genetic test. And each genome is well known to metabolize certain medications. So when we do this test, the test will basically identify which genomes are not functioning properly. And when we know which genome is not working properly, we can identify the medications that may be poorly metabolized. And so when we get those results, we can better understand and predict the effectiveness of the drugs and the medications, guide the dosage better, and also improve the safety of the patients taking these medications. A little bit of science, a little bit of background on this pharmacogenetic testing and genetic testing. In 2003, we were able to accurately and completely get or finalize the human genome sequence. That was 2003. So since then, we had this amazing information about the human body and the human genome. And so mostly the people at the Mayo Clinic said, we have this great information. How are we going to use this information and make it practical? How can we put it into practice? And so it was mostly the Mayo Clinic that pioneered, establishing and developing these tests. And they did that evidence-based. And so today, most insurances cover these tests. And now we have a practical application. So let's talk a little bit about this evidence-based science. This is a great example. It's a peer-reviewed study that was done with the title Clinical Impact of Pharmacogenetic Profiling with a Clinical Decision Support Tool in Polypharmacy Home Health Patients. So basically the outcome was, compared to the control group. So we put these people, we did the pharmacogenetics test, the drug interaction test, and we compared to a control group that we did not do the test on. And so what we saw here that 52% fewer hospitalizations in 60 days and 42% reduction in emergency room visits also at 60 days. Pretty significant, I would say. This is a study from Vanderbilt University Medical Center. And what we see here is on the left of your graph, we have a 57-year-old with type 2 diabetes, family history of heart disease, admitted for high cholesterol, chest pain. And what happens is he receives a stent. And so for 9 straight, actually for a whole year, not 9 months, for a whole straight year, the Plavix that they put this patient on seems not to have any therapeutic benefit. The patient in that year is admitted 9 times to the hospital and receives 9 stents. After a year, they decide to do a pharmacogenetics test, a drug interaction test, and the results show that this patient is a poor metabolizer for Plavix. So at this point, they changed the Plavix to another antiplatelet. And what we found out is that now, the drugs works properly. Not only did they put the patient to horrible treatments and surgeries and suffering for a whole year, but there was also over $100,000 spent, which obviously could all be prevented if we would have done or conducted this test in the beginning. Another study that was done on 112 long-term care residents. Again, the PGX was performed and almost half of these residents needed a medication change, or at least it was recommended that they change their medication. And so we see that, the reasons for medication change was genetics, drug interaction, and then regimen consolidation and drug disease state interaction. Again, besides patients being on a more effective medication and having less adverse reactions and be on a safer regimen, also there was a cost savings of an average of $1,300 per patient annually. One more, guys. This was Jane. Jane was diagnosed with depression and anxiety. She was put on antidepressants, and for 9 months, these medications did not work at all, no effective treatments. After 9 months, the PGX test was performed, and we got complete remission within 3 months. Again, we could have saved the patients some agony and put them on better medication by doing the PGX test initially. But again, we also would have saved almost $12,000 in expenses. So we have the science, we have evidence-based science, we have the Mayo Clinic that pioneered and took that information of our complete and accurate genome and put it into a practical applications. And now insurance companies covers it. The problem that we at Genomics saw is that even though it's available to patients, patients cannot get this testing done. And why is that? Because this testing is not available at most offices and most clinics. And so the mission of genomics is to put these tests, pharmacogenomics tests and genetic testing, into the clinical settings so patients can benefit from the results of these tests. Now, when you partner with genomics, you have a few advantages. First of all, when we go to doctors' offices and clinics, we can tell the doctors that almost all insurances cover this genetic testing. And that's because at Genomics, we have contracted with several laboratories. Because if you go with just one laboratory, they are limited in the tests that they can provide, but also limited in the insurances that they can accept. So we are unique in the sense that when you align yourselves with us, you can test all your patients regardless the insurance they are on. Another great benefit is that we have a geneticist on board with us on staff. And a geneticist basically is a pharmacist that is certified in genetic testing and genomics. And so that is very helpful because when our physicians get a 15-page report talking about drugs and drug interactions, often they don't have really the time to review that report carefully. And often our physicians do not always have the expertise to make proper recommendations on drugs and drug interactions. So this work will be done for you because our geneticist will basically review the test results and take the medical conditions and medical history and the current medications of the patient into account to make the recommendations. And then so you can give those recommendations to your patients and improve their quality of care. So those are the unique points that I wanted to give you on why it's important to align yourself with genomics. Now, the report basically identifies again whether or not a drug is metabolized properly. So the geneticist makes those key determinations whether or not a patient medication is metabolized properly and whether or not we should alter the dose or just alter the medication. And so you could actually find a sample report if you would like to look at it on our website, genetictestingnow.com. And if you go to the provider page and click physicians, on that physician page, we have a PGX sample report posted for your review. And that report will show you whether or not the patient is a poor metabolizer, intermediate, extensive, or ultra rapid metabolizer. And that's important. And a good example I can give you, for example, if you have a patient on pain medication, hydrocodone or oxycodone even, and the patient keeps telling you that the dosage that they're having is not working well, that it only lasts 2 hours and then they're in pain for 10 hours until they can take their next dose. And so you're wondering whether that patient is telling the truth or not. If we would do this PGX testing, it would tell whether or not the patient is a poor or rapid metabolizer. So let's say this patient is a rapid metabolizer, meaning the patient is telling the truth. The oxycodone is, metabolized fast, and therefore the patient is in pain, the rest of the day maybe. So in this case, it may be prudent to adjust the dose and give the patient a higher dose. Okay, so from the pharmacogenetics, let's talk a little bit about the genetic testing for those medical conditions. We can test for cardiovascular disease, we can test for cancer, diabetes and obesity, we can test for pulmonary disease, and we can test for neurodegenerative diseases such as Parkinson's, Alzheimer, and dementia. And so what would be the reason for this testing, right? The first reason would be is if those patients already exhibit or are already diagnosed with the disease, it would be good information to find whether or not genetics played a role. And having that information may or may not have an effect on your treatment plan with that patient. This testing can also be utilized for patients that do not have those diseases yet, but have preconditions. For example, let's take cardiovascular disease as an example. If somebody has high blood pressure and high cholesterol, it may be a good idea to get this testing done to see if they are also genetically predisposed or at a high risk for cardiovascular disease. If the test comes back positive, this test will be very specific. It will identify the gene that is positive, and that gene is directly correlated with a specific symptom or a specific cardiac disease. So that's, again, great information. Either way, whether the test is negative or positive, it's valuable information that we get from this testing. Again, if we test a patient that just has the preconditions, for example, high blood pressure, high cholesterol, we do the test for cardiovascular disease, for example, and the test is positive. Now we can, encourage the patient to enroll in preventative measures, whether or not you offer those measures at your office or whether you have to refer them something else. We can do something to prevent that patient from getting this cardiovascular disease. For those of you who are familiar with epigenetics, we all know that the science of epigenetics shows clearly that yes, we can be predisposed to a certain medical condition, but we also can change that genome and make sure we don't get it. And so for those of us on the webinar that are not familiar with epigenetics, Google it. It's a pretty interesting science where we can basically control our genes and change those by usually simply modifying some lifestyle habits. Okay, so by simply incorporating these no cost and easy to implement tests into your office that are covered by most insurances, you will definitely improve the quality care of your patients by, number one, improving the effectiveness and safety of their medications, reducing adverse drug reactions, recommending alternative medications, suggesting safe dosages, reducing treatment failures, and of course, limit drug interactions and subsequent hospitalizations. We have seen the data earlier in this presentation. We also can better assess the risk or the causative factors of medical conditions by collecting the genetic information for certain medical conditions and by assessing the risk for certain medical conditions. We obviously can save time and money, but most importantly, guys, we can save our patients and make sure that they are on the right medications. Now, for those that need to go back to work, because we are getting already into our FAQ section, but if you need to go, you can get started by going to our website, genetictestingnow.com, go to the provider page and then select the physician page. And at the bottom of our physician page, we have the provider pre-qualification application. It will take less than 5 minutes to complete that. And as soon as that is submitted, we will assign an account representative to your account who gets in contact with you and get you going and get you started. Unless you obviously already have an account representative, then they will take it from there and get you started. For the rest of us that will stay on the webinar for a few more minutes, here are some of the FAQs. Actually, not yet. First time we do the webinar. One more slide before we get into FAQs. If you already have an account representative, great. If not, we will assign an account representative to you. But there's three easy steps to get started. Nothing's complicated here. Number one, we will apply to the laboratories. And once we apply to the laboratories will send at no cost all the supplies to your office or your clinic, including the swabs, the requisition forms, the FedEx bags, the biohazard bags, and everything that you will need. The second step is we will set up a training at your office. The training will be short, 30-40 minutes. We'll spend only 10 minutes with the doctor to inform the doctor about which patients qualifies for which tests. So we will talk to him about the ICD-10 coding. After that 10 minutes with the doctor, we will talk about the person who actually will do the swabbing, which probably is an assistant or an MA. And so we will educate the MA on the, how to properly collect ample saliva, because we need obviously enough DNA. And we will instruct that MA in, filling out the proper requisition forms. And then X amount of weeks later, we get our first results. And at that point, we will train on how to interpret the results, how to collaborate with the pharmacist, if at all necessary, and how to upload these results securely into your EMR system. So very distinctive steps, very easy, but we start with the first one is signing you up, applying for the laboratories, and getting the supplies. Our FAQ session. What insurances cover the test? Well, these tests are covered by straight Medicare, Medicare Part B. Also, by most Medicare Advantage plans, including Humana, United Healthcare, WellCare, Optimum, and you name it, and also by most commercial insurances. So again, most insurances will cover this test. Another question we get often, is there a copay? No, there is no copay. However, when we do the swab, that person is going to ask the client or the patient about their deductible. So they will ask whether or not the deductible is met. If the deductible is not met, the patient will be informed that the lab will legally have to send them a bill that will be, or that is supposed to be paid towards the deductible. However, the laboratories that we at Genomics contract with will not send patients to collections. So obviously the patient will have to read between the lines and basically decide whether or not they want to pay that bill. Next, when does a patient qualify for this testing? Obviously, in order for insurance to cover, we need ICD-10 codes on the requisition form. And so it's actually pretty simple, and that's part of the training. But to give you a few examples, for the genetic testing, if you have a cardiac disease already, like congestive heart failure, you had a heart attack, you had stents, you obviously qualify. Same for all the other panels, diabetes, neurodegenerative disease, pulmonary disease. If you have the disease, you qualify to get the testing done, just to find out whether or not genetics play the role in you acquiring the disease or in the patient acquiring the disease. But besides having the disease, if you have 2 or more preconditions to that disease, again, the simple example is cardiovascular. If you have high blood pressure or high cholesterol, you qualify to get the cardiovascular test. For diabetes, if you are obese, if you have a high BMI, if you have hypothyroid, if you have high blood pressure, high cholesterol, if you have kidney disease, stage 1, 2, 3, or 4, any combination of any 2 will qualify to get the testing done. Same for pulmonary. For cancer, you have to have a personal history of cancer, etc., etc. I wouldn't worry too much about that because that's going to be part of the training. When it comes to the drug interaction test, we need to have the patient obviously on 2 or more drugs, which is basically all your patients, right? But those drugs need to be different classes. So it could be pain medications and antidepressants, or pain medications and anticoagulants. And so it's pretty easy for a patient to qualify to get this drug interaction done at no cost. So those are the ICD-10 codes, and we obviously will provide you with a complete list of those codes for each specific test that we offer. Can a patient get all the tests done? Well, at this time, a patient can get 3 tests done in a lifetime. For example, we can run the PGX today, we can run a cardiovascular panel on the next visit, and maybe next year we want to run a diabetes panel because they are gaining weight. After 3 tests, we can not run any more tests in a lifetime. So the only solution at that point would be to change insurance companies, right? Are the results or the data protected, or are they shared for research? So every time we test the patient, the person who does the swab will each time ask the patient whether or not they want to opt out of research. And then we basically simply check off that box on the requisition form. So if the patient is concerned that their data may be shared, we make sure we check off the box, and then that data stays protected and cannot be shared by the laboratory for research purposes, or maybe even sold to the government or whomever, right? So every patient has that option to select out and keep the data private. How long does it take to get the results? Usually it takes 6 to about 8, sometimes even 10 weeks to get the results. So there is a little bit of time that lapses between actually sending in the swab and getting the results, but that's usually not a big deal. And the other question is, how do you collaborate with the geneticist? Anyway, we have an automated system where the laboratory downloads the reports into a secure portal. And then our geneticist or pharmacist looks at the results and makes the recommendation. Once the recommendation is made, we download that report and upload it to your EMR system. So when the physician finally gets the report, The recommendation is on top of the 15-page report, and it makes it easy for the physician to make the recommendations to the patient and maybe modify the dosages or the drugs the patient is taking. Now, the geneticist also will be available for collaboration by phone or webinar with the physicians in our network. Do you have any liability? Well, when it comes to the genetic testing itself, testing for the medical condition, no, because we are not diagnosing the patient with cancer or cardiovascular disease. This is just finding out whether or not that patient is at a higher risk or is predisposed to a certain medical condition. And it's not a diagnostic tool, so there's zero liability. When it comes to the drug interaction test, there is no liability either. However, it does make sense that when you order a drug interaction test for a patient, that you're actually going to look at the results and look at the recommendations and do something with those recommendations and record it into your notes to protect yourself, right? So we don't want to just swap to swap. We want to actually look at the results and help our patients having more effective medications and be safer on those medications. But the short answer is no, there's no liability. Do you do the billing at the office? No, there's no billing involved. Even if you don't accept insurances and you are a membership or a VIP clinic, there's no worries. Because just like when you would send a patient to LabCorp for blood work, it is LabCorp that would, charge the patient's insurance and does the collection. So same here, we do the swap, we collect the insurance information, the demographic or face sheet, and we fill out the requisition form, and that information goes to the lab. The lab will do the insurance verification, the lab will charge the insurance, and we just get the results in our portal, okay? Do you need to do paperwork? The doctor just needs to do the SOAP note, and the doctor's going to do a SOAP note anyway. At Genomics, what we do is we provide the templates or the inserts for each test. And so we will make sure that we find the easiest way to upload those templates into your EMR system, so you simply can click and paste those into your SOAP note for that day. And that's all that we need paperwork-wise, of course, with the demographics, etc., to send off to the lab. Can you market these services? Yes, it's one of the advantages. You can market genetic testing. And if you're still looking to increase your practice and attract new patients, it may be a lucrative way of getting more patients into the office, educating the people out there that you're offering this drug interaction test, that you better manage those drugs, and that you can also do the genetic testing. We also offer, at no cost, a in-house banner for in your waiting room, if you like it, to talk about the genetic testing. We also offer rec cards that you can put in a brochure holder in your waiting room. And we also provide you with social media ads that you can use on your website or on your social media to attract new patients to get this testing done, if this is something that you would be interested in. But yes, you can market these services. Do you make a profit? Again, we're in the business to helping our patients better manage their care and improve the quality care of our patients. When it comes to laboratory testing, we cannot make any direct money of those testing. It would violate kickback laws and Stark laws, as many of your healthcare professionals already know. The little profit you make is obviously when you discuss results with a patient, you upgrade the charge for that patient visit. You also could schedule an extra visit to discuss these results with the patient. But otherwise, there's not much profit you can directly make from this testing. Another example would be if you have a positive outcome or test that says a certain patient is a higher risk for diabetes or cardiovascular disease, maybe you can enroll them in an ancillary service or a preventative program that you offer at your office if you do so, such as a weight loss program. Many people could utilize a weight loss program, obviously. So that's where you would make your profits. If you are part of an ACO, an accountable care organization, how do these tests benefit you? Well, obviously, when a patient has a certain dollar amount available, we don't want to do unnecessarily tests. test the patient. So maybe the genetic testing for cardiovascular disease as being part of an ACO may not be the way to go. But as you learned today with the PGX or the drug interaction tests, you may be able to better manage the care of those difficult patients, those that are difficult to manage, the patients that get in and out of the hospitals, the patients that rack up the bills, the patients that we have, difficult time managing. And so when we do this PGX test, we can get some valuable information to better manage their care and hopefully keep them out of the hospitals and reduce their drug interactions. So even if your practice is part of an ACO, there are many benefits, not just to the patient, but also to you as an ACO member to provide the drug interaction test. So before we open this webinar up to live Q&A, the only way to get started here is go to the website, genetictestingnow.com, or get with your account representative if you have one. Click on the provider page, select the physician page, and on the bottom of the physician page, you will have a provider pre-qualification application. That application will take less than 5 minutes to fill out. As soon as you submit that application, we assign an account representative to you who will be in contact with you and start the 3 easy steps to get you started on this very innovative medical testing that will increase the quality care of your patients. So I'm gonna stop sharing the PowerPoint and we will open this up for some live Q&A. So just raise your hand if you want to ask a question and I will unmute you. Anybody, any questions? No questions. All right, I guess everybody was very clear. Everything was very clear. I just wanted to give everybody a little bit of more background on the importance of the PGX or drug interaction test, especially. There's plenty of scientific evidence out there that shows how we really can help the patients manage their medications and their drugs, fewer hospitalizations, fewer costs, but more importantly, less suffering for the patients. Okay, thank you everybody for joining, and we will continue to be in touch and continue to get more people interested in incorporating these services into their offices to help our patients. Have a great day.